Good, Good afternoon to everyone. My paper is on central corneal thickness and intraocular pressure in persons with diabetes mellitus in tertiary care hospital. So the rationale of the study is that diabetes mellitus is a serious and increasingly prevalent global health issue primarily driven by sedentary lifestyle. And there are studies as indicated that POAG is directly linked to diabetes, and it has also been seen that thicker central corneal thickness is seen in diabetic patients because intraocular pressure is one of the major modifiable risk factor in glaucoma, and it depends upon the central corneal thickness measurement. There is an importance in checking the central corneal thickness of diabetic patients. So the aim of the study is to estimate central corneal thickness and intraocular pressure in persons with diabetes mellitus. So the study design is cross-sectional hospital-based and descriptive study with a sample size of 237 patients, and study population included all diabetic patients attending the ophthalmology OPD of our medical college during the study period, and meeting inclusion criteria were included after obtaining consent. So the inclusion criteria was patient aged between 20 to 60 years with diabetes mellitus presenting to ophthalmology OPD with informed consent. And exclusion criteria excluded patients who had corneal scarring, dystrophies, active keratitis, who had history of usage of hard contact lenses, undergone refractive surgeries, leukoma, anophthalmia or phthisis bulbi, and patients who were on medications such as antidepressants, anti-Parkinson's drugs, antipsychotics. The data collection included comprehensive history, including duration of diabetes, was gathered using a standardized performer for each participant, and complete ophthalmic examination, including visual acuity using Snellen's chart, slit lamp examination, fundus examination was done. Intraocular pressure was precisely measured using Goldman's apparition tonometry, and central corneal thickness was determined using ultrasonic pachymetry. So lab investigations included HbA1c, FBS, and PPBS, and data analysis was entered to MS Excel, and statistical analysis were done with SPSS software. Informed consent obtained from all participants, and information was solely used for the study purposes with strict confidentiality maintained. So results was 237 diabetic patients. In that, 55% were females. Median age was 58 years, and median diabetes duration was 5 years. So HbA1c control was divided into good, fair, and poor control, and 62% had poor control in our population study, and 35% had fair control. So mean IOP in our study population was 12.79 millimeters of mercury, and 46% had diabetic retinopathy out of 474 eyes. And mean CCT was 552 micron, which was within normal limits, and central CCT was classified to normal 522 to 586 microns, and more than 586 was taken as high. So here we tried to correlate central corneal thickness with diabetes duration, HbA1c levels, and presence of diabetic retinopathy. And it was seen that 62% of eyes with thicker corneas were directly linked to a longer duration of diabetes mellitus. And it had statistical significance of p-value less than 0.05. So this is a chart on the table. A similar study by Anna M. Calvo also had similar results in her study. And we also measured HbA1c, and we have seen that there is a direct correlation between HbA1c and central corneal thickness. That is 82% of people who had thicker central cornea thickness were associated with higher HbA1c values. B.T. Chowdhury's study also showed similar results. Then we divided people who had presence of diabetic retinopathy and absence of it. And it was seen that who had thicker central corneal thickness were diagnosed with diabetic retinopathy. Osdamer et al. Study also showed similar results as our study. So key conclusion from our study is that a direct correlation exists between longer duration of diabetes with thicker central corneal thickness and poorly controlled diabetes, as evidenced by higher HbA1c levels, is also significantly linked to increased CCT. Patients with diabetic retinopathy exhibited notable association with thicker corneas. These were my references. Thank you.
Getting better based doing the better controls. Was the CCT changing or staying?
This was a one time we checked the CCT, not a serial CCT was not checked. It was the downside of one of limitation of our study. We have to do continuous one year. If we do it, we would get.
The time when the CCT was raised, did you apply the correction factor to the IOP?
Yes, we gave the IOP correction factor was done. Yes,
corrective
yeah.
pressure.
Each time the IOP, after measuring CCT, we measure the IOP. So we can correct the measure.
Whenever the CCT showed high rise, did you anytime measure whether it was stromally getting thick or whether it was epithelially getting thick?
No, sir. We require a specular microscopy and rest of the stuff we do not have. Yes, sir.
So what was the type of study?
It's a cross-sectional study.
Cross-sectional? Did you have a control arm?
No, when we thought of taking a control, so but our ethics committee was like, if you take an control, then we will be doing an invasive, like even if it's intraocular pressure measurement, where they were like, we are, it's a control, there will be some ethical problems.
Then
as well.
if you don't have a control arm,
Yes,
so how
control.
can you say or diabetic patient have high thickness, corneal thickness?
Comparing with others and comparing with other studies which were conducted in India, which
So we
measured,
took historical control.
yes,
That you should mention in as a limitation of the
yes, yes,
study.
yes.
Because every population, your population may have a tendency of higher thickness. So to rule out that, you need a control arm. If you're not using that, then you should mention ki the limitation of the study is we took a control from a historical control. So what is the rationale? How do you explain why the thickness should increase in diabetes?
Okay. So one is there are more damage of endothelial cells in diabetic patients because of there is accumulation of sorbitol, accumulation is there, and an increased
Is
amount.
this thickness is related to endothelial damage?
Yes, because stromal thickness will increase if there is endothelial damage. There's more imbibition of fluid into the
Then
stromal.
that should be a continuous process, right? Over 5 years, the endothelium will further decompensate. The corneal edema will be permanent. So do you think, do you find such cases in diabetes where cornea is decompensated?
After surgeries and all, I've seen pseudophakic bullous.
Yes, so normally we don't find diabetes as a cause of endothelial decompensation. So what could be the other explanation for increased thickness? Go back and have a hypothesis for that. Endothelial decompensation cannot be a factor for this thickness. Why the thickness? Is it due to deposition of advanced glycation end product, basement membrane thickening? And sir also pointed out that, right? Epithelial thickening is there or stromal thickening is there. That will add more value to your study. Anyway, good study. Thank you.